Dr. Rohit Om Prakash to please come up and please deliver your talk. Thank you so much.
Thank you, Dr. Priya, for inviting me over. So she has asked me to talk on addressing zonulopathy with CTRs, segments, and devices. Well, the basic fundamental in management of subluxated cataracts or zonulopathy is that we need to conserve the intact zonules, we need to create an intact rhexis, we have to complete the different steps of phacoemulsification and implant IOL with bag fixation to the sclera. So these are the basic fundamentals around which the whole game is. Well, we have to realize that there are certain basic pearls which we have to know. As far as the planning is concerned, a detailed history is obligatory and mandatory. Both eyes need detailed examination. Slit lamp examination for phacodonosis or some subluxation has to be seen. Dilated pupil examination is obligatory and mandatory. Supine position is required for us mortals, but not for Dr. Chi because it doesn't make a difference how much subluxated it is. But we people, I like to do a supine examination to see the extent by which the lens, when the patient lies down, how far it goes down. There are different ways which Dr. Chi would show how she pulls it up. Site of incision is very important. That should be not ideally in an area where the zonules are not there. Choice and timings of capsular hooks is also very important. We have moved on from implanting CTRs in the beginning with capsular hook. Now capsular hooks have come, which have helped us delay, the insertion of CTRs. So CTR insertion, in other words, needs to have the insertion technique is very important. The timing is very important. Cortical cleanup, how you have to do, and not to forget the how we use the nucleus as a scaffold, which can help us delay the insertion of these external aids. Scleral fixation of IOL, different means. We have all a big array of methods by which we can. So let's see first the signs of zonular weakness. You can find that there is difficult because of lack of counter traction to start the rhexis. So this is another patient where you will find that there is striae formation. So this shows that there is a sign of weakness. Another patient where you would find that the weakness is there. You can use a pointed tip. You can use a cystitome for that matter. You can use in these patients where the insertion is difficult. You can use by what do you call Zepto for your advantage. You can use Femto also. So these are the different things how you can initiate the rhexis. So these are the different methods how you can. So it's a double pinch method which is being used to initiate the rhexis. So that is one way. This is the radio frequency by Herschel Tuck, courtesy him. He uses this to create a rhexis. Then Fugo blade can be used. I don't know how many of us have Fugo blade. Zeptorhexis can be done, and you can do a Femto too. So these are the different ways how you can initiate the rhexis. At times, the patients do have pseudo exfoliation, but contrary to your expectation, the zonules are intact. And the idea in these patients with zonulopathy is to create a large rhexis, as David Chang has taught us. So this is another way how we can do the rhexis. This patient has, you will find that there is some bit of subluxation in this part. So first of all, the most important point is that we are farthest away from the point of where the zonular weakness is there. And the initiation has to be in the direction, and I find that it is difficult. Stable chamber settings, then you can use a pointed chopper, a pointed cystitome to your advantage. Then you can start doing this, and once you reach this point wherein you have created at least 1 to 2 hours clock of rhexis and the flap of rhexis, this is the time when you can insert a capsular hook. there's a big no. I delayed it. Ideally, it should not have been delayed. And, so capsular hooks in this patient is being used. Ideally, capsular hooks should be used, and one should not use iris hooks, because capsular hooks, they help us. How do they help us? They act as artificial zonules. They provide anterior-posterior immobilization, and they, make there's no tenting up which you see when you use iris hooks. So now I'm just continuing. The moment I reach there, I'll use another capsular hooks to my advantage. You can use a bi-manual also, as Professor Chi shows, wherein one, capsular access forceps holds the capsule, and that, immobilizes it, and you can use the other rex's hook, other rex's forceps, and you can continue with the rexes, and you can go on holding it again and again. So this is how the capsular rexes was completed in this patient. I used 3, or at times one can use even as many as 5 to your advantage. So this is how I use, and now the capsular rexes is moving without any problem, because the rexes, the capsular hooks have been able to provide me with the as artificial zonules. So now once this is done, there is adequate support, and one can continue with phacoemulsification. So this is another case which I would like you to see. Now here you would find that there is a around 100 degree of subluxation. So I've created the Hoffman's pouch right at the beginning, because that is the time when the globe is firm. Otherwise, at times you have problem, and then I'm making the Hoffman's pocket. So once that pocket has been created, 1.7 mm, so incision site is right opposite the where the zonular dehiscence is there. Calibrated site port incision, because I want that the chamber should be absolutely stable. I'm using a cystitome, and I realize that I was able to initiate it. The direction of rex's the initiation has to be in the direction from the intact to the area where the zonules are not there. I'm trying to create a rexis. The rexis has to be created in such a way that it has to center the lens rather than center the pupil. I found that the rexis was too small for my liking, so I just spiraled it around and completed the rexis. So I've started using you see the fluidics which I'm using. The fluidics which I'm using are around 20. When I'm using 20, I'm trying to create in a situation wherein there is less flow of fluid into the anterior chamber, because it has been shown by Vasavra et al. That if we use high fluidics, an intact anterior vitreous face can be broken, and you can have a vitreous prolapse. So having stable chamber settings and low fluidics is a very important factor when we are doing this, managing these patients with zonulopathy. Oh. So I had reached here. So now I'm continuing, I'm doing that, chopping it. Now, doing sort of, reverse chopping as Ronald Yorn initially, our own Dr. Chi had shown. So so now I'm rotating it. Now I'm going to show you a trick which I use. You should see that this area has zonular dehiscence, and this is a fairly hard nucleus. So now what I'm going to do is, I'm going to use this nuclear fragment as a nuclear scaffold. So when I'm using it as a nuclear scaffold, what I'm doing is that this nuclear scaffold, this hard nuclear fragment, is tenting up this area and helping me delay the insertion of a CTR. So this we published in JCRS way back in 2019. So you will find that I'm continuing to cover this area. So this is another very small thing which you should bear, stable chamber settings. Now when the last nuclear fragment is there, I'm putting a CTR. So CTR direction is also very important. So CTR direction, you should, if the zonular dehiscence is less than 90 degrees, you can put it either where the zonules are intact, but when it is more than 90 degrees, then you should go from the area where the zonules are intact. Dr. Chi, any comments about that? Would you like to add?
I think just once you have hooks in place, to me, as long as you fully fill up the bag and distend the bag, it doesn't matter which way you go.
Yeah, but if that has not been done,
If that's not been done, then you go from intact to non-intact.
yeah. So that is a very important factor, because yesterday Dr. David Chang showed spiral CTR. I think when he'll come, he'll show, and I think it's a wonderful this.
Not that easy to use. I have it. I prefer the standard plain injector.
Okay.
Much more difficult.
And
to
what do
maneuver.
you do? The tricks which you use for each one of us here to decrease the zonular stress, which is there with the normal CTR, which is not there with the, the spiral CTR.
So I think what I do is the first part, I don't inject all the way. So I will just withdraw my injector. If I start injecting here, which is my favorite place, and then I will actually, as I push the CTR out, I will move my injector this side. So I'm not advancing this tip. I'm just laying it out here. And once at least 3-4 hours has been laid out, I then advance it. So it's already following the curvature of the capsule.
And you don't use an injector, don't
I
you?
use an injector.
So you use the injector through that side port?
Yes. No, through the main incision.
Through the main incision. Okay. So this part done, so nuclear scaffold has been used. So since this was more than 90 degrees, so what I would be doing, so stable chamber settings. Now what is the trick in using, with CTR around, it becomes difficult to take out the cortex. So just see the direction in which I am doing. I am doing tangential stripping. So that can be done, or as Dr. Mohan Rajan says, you can do reverse stripping also. In reverse stripping, what he does is, if you're finding it difficult, you can go from the posterior lamella and go do it. So I'll be putting a 3-piece intraocular lens. Once that is in place, so I'm going to railroad it in. So that is how I'm railroading it in. And then I'm going to pull it out, and the IOL is centered. Okay, so I don't need. So next is, when there is an extreme subluxation. So I would like to make it interactive, because, there are different ways how you can bell the cat. And with Dr. Chi around here, I would take the advantage of her presence and, see how it has to be done. The pupil was not dilated in this young child. So I used intracameral adrenaline to dilate the pupil. Now I'm doing the compartmentalization, so that there are different compartments, because I really do not want by any means, the vitreous to come forward. So once that is done, the air bubbles out. I've initiated the rexes. So this rexes, Dr. Chi, you can stop me wherever you feel you want to.
Yeah, just to make comment that in all these very young patients, right, even in the Marfan syndrome that we saw, sometimes when we use the word that this is a subluxated lens, we tend to think that this lens has shifted, but actually that's not so.
Yeah.
All right, it's just that the zonular support is loose there, so the lens has become more globular. So the shape has changed, but it has not actually shifted. So sometimes we do the capsule rexes, we think that this lens is here, and we want to put the rexes here, but actually not so. If this is the shape of the lens in a young lens, all right, or even a person who's had zonulisis from trauma when they were young and then became older before they presented to you, and the lens is this shape, I would make the rexes follow the shape of the lens. And when you put the CTR in, you'll find it's perfectly circular and centered.
You will make it go like this.
I'll follow the shape.
Yeah.
Okay,
Great. So I think it's a learning all the way for me also. So now what I do is, I've started it. You see I'm putting stress to the zonules. So what I'm doing now is I'm inserting the capsular hook. Here also I committed a mistake, because I want it to be a learning one. I have taken it too far without the support of the capsular hook. Either I should have used the bimanual as Dr. Chi does it, or I should have, used capsular hooks to my advantage. Since the child was young, I was able to get away with it. So that is the thing which, you should learn from what I have done. So once this part is done, now comes how do I take care of the cortex out here. I'm trying to do, hydrodissection, which I'm not able to. So now I'm shifting to viscodissection. When I'm doing viscodissection, I've been able to separate it fully. So this is something, which you should. My question is, should at this point of time one implant a CTR, or would you wait for it? Because when you're trying to do, had I not visco dissected it, in that condition I would have put in, a CTR, because between the capsular hooks there is an area by which when you are aspirating, that can be aspirated. Your comments on it?
Actually, you don't need to hydrodissect and you don't need to viscodissect because it's so soft. You can just aspirate it like a congenital cataract because there's no nucleus in it.
Yeah.
And you could consider in this case using a CTS with the iris hook as your retractor because it would more evenly spread out the forces and make it more centralized.
Good. So I continue now. So when I am able to, you see how I have retracted it. So why I have retracted it? Sleep. Ideally, one could have used a bimanual, because what you want is, you want to have different planes of irrigation and aspiration. So in this case, I have retracted the sleeve. The irrigation is at this level, aspiration is at this level. These are very small things. And you can see that the IOP which I am using, IOP is 28. With this 28, what is happening is, I am not in any way going to create a situation wherein there is going to be, break of anterior vitreous phase. No doubt in this children with some support of zonules, it's difficult, but still low fluidics will really help. So I continue now, and so I'm able to, achieve the delivery, the aspiration of the cortex matter, because the child was too young for anything, and without any issue it has been done. Stable chamber settings, these are very small things which you have to realize, because you are trying to, as I showed in my first slide, you're trying to conserve the zonules as well. So now once that is done, CTR is being pulled in. I would have preferred that this CTR should have gone like this. So it is going in like this. Dr. Chi, is it okay if I continue like this?
Yeah, no issue.
No issue, yeah. But in your hands. But yes, for novice surgeons, you should ideally go do it the other way around. And how do you see that the capsular hooks don't come in the way in such a situation?
I think it's a different plane that you're inserting it, so it really doesn't get engaged.
It doesn't make a difference. Yes, absolutely correct. So I'm moving on, and at this point of time, with almost in, what I'm going to do is I'm going to use the Sinskey hook to just push it in. So once that is in, now I'm going to use the CTS. So there are different ways how you can fix the bag. So what is do you use CTS or do you use, yeah, please.
Just a CTS should be adequate.
Yeah. So there are many devices nowadays, which people use. So you just place it in. So ideally Gore-Tex should have been used. So which I think she would have asked me why did I use, because that is not so freely available in India. So these do have natural fragmentation of the of these sutures. So I'm going in. It's a partial sclerotomy which I've created. Railroading it in. So you have to be wary of the fact that when I'll just show you when I do it again. So I'm just taking it out. Now I want you to see what I'm doing, because I'll move it left, right. Why? Because I do not want any entrapment of the corneal tissue, because at times if you do a corneal entrapment, it creates a, yeah, Dr. Chi, you were about to lift the, yeah, okay. So I just do it and then I take it in, I railroad it in, go, then move it. This is unedited because I want you to see how, you know, if with both your hands, you know, you're able to, and see how closely I am holding. One should not have a long, you know, for better control, I would like to you to see how I did it. Because this is also very, you see how close I am holding it. So when you hold it close, you have better control. Dr. Chi, would you like to add something? How do you hold it? It doesn't make a difference.
It doesn't make a difference,
But-
I think.
But
But be careful when you pull it across. If you have a long needle length, it can prank the PC at this stage.
yeah, and
Yeah.
that is also very important. So for better control, for two things, corneal entrapment, and if you have a longer one, you will not have a good control. And I have had a PCR with a long control. I couldn't control it, and I just hit the posterior capsule. So this
So
is
the other thing I was going to say is that, you know, if you have a problem trying to get your needle in, especially if you have a small pericentesis, then I just put my viscoelastic cannula and I just follow along.
okay.
Because the viscoelastic cannula will open up your incision. So you just follow your needle along your viscoelastic cannula and then you'll get into the AC without catching the corneal lamella.
Okay, great. So now I think I've already shown that. So this is going in. The second one. I'm pulling it. Now I will center it. The capsular axis is small, but somehow it is centered. Would you have preferred to have a larger one, or it's okay?
As long as your IOL can get in.
Yeah, now the lens will be implanted and that will be done.